SUDEP stands for Sudden Unexpected Death in Epilepsy, and it is exactly what that name describes, and it's where someone who has epilepsy dies suddenly for not an obvious reason. It occurs across all different forms of epilepsy, and there are many, many different forms of epilepsy, because epilepsy at its basis is actually a symptom rather than a disease. It's a symptom of many different brain conditions, from genetic through to acquired, such as traumatic brain injury or brain tumours. And any of those epilepsies, if the seizures are uncontrolled, they can result in SUDEP. What we think happens during a seizure is there is a major seizure activity that after the seizure there's disturbances of control of breathing and cardiovascular function, which doesn't come back to normal for a period of time, and during that time people are vulnerable to stopping breathing and then having a secondary cardiac arrest. And the usual circumstances are someone is found dead in bed, and usually lying face down in bed. Presumed they've had a seizure. There may be evidence they've had a seizure, but that's not always the case. About 1 in 1,000 people with epilepsy will die of SUDEP, so it's the most common reason someone might die from their epilepsy. And in younger people, because they don't die from a cancer or a heart disease or other common causes of death nearly so often, it really stands out as a really important cause of death in people that are under 50. When you have difficult to control epilepsy, drug-resistant epilepsy, which is about 1/3 of people with epilepsy, then that risk can go up to 1 in 150. And while the estimates of how many that represents in the Australian population vary, depending on how you measure it, there are estimates of up to 200 people in Australia each year die of SUDEP. So it's a really common, important community problem that's much under-recognised. Do we talk, or should we talk to our patients and their families about SUDEP? I think the short answer to that is absolutely we should. Do we as a profession, a medical profession, do that very often? In fact, probably not, and not nearly as often as we should.
People can't completely protect themselves against SUDEP, and that can contribute to a lot of anxiety for people who potentially already are living with the condition. That can cause a lot of uncertainty in their lives. And I guess on the whole, doctors want to support people and have positive conversations, and SUDEP, sometimes it can be challenging to fit that into the paradigm. Personally, I work in the first seizure clinic, and so my patients tend to have new diagnosis epilepsy. There's an awful lot of content to cover. Why has epilepsy come now? What are the treatment options? How does this impact my health and my family and my work life and my driving? And so working SUDEP in needs to be done sensitively and at an appropriate time. I find that if people choose not to take anti-seizure medications, that is a time when I would discuss SUDEP with them, just because we know that's a risk factor for SUDEP. And I think that information helps people make an informed choice about their decisions.
Knowledge and patient empowerment are essential when delivering SUDEP counselling. It's important to have a patient-centred approach and factor in their individual risks as well as their care. It shouldn't be a one-time discussion. It can have multiple levels of engagement depending on that patient and their individual risks, so that those risks can be weighed against their benefits. By far, the biggest risk factor identified in studies is not only the presence, but also the frequency of tonic-clonic seizures in the past year. So compared to someone who has no tonic-clonic seizures or major convulsions in the past year, someone who has 1 or 2 seizures has a 5 times increased risk of SUDEP, which increases to 15 times the risk when they have 3 or more convulsions in the past year. Being refractory and having ongoing seizures for 1 to 4 years can also increase that risk. Living alone, not adhering to anti-seizure medications, as well as substance disorders, as well as alcohol withdrawal, may also potentially contribute to increased risk of SUDEP. We know from lots of research that seizure control reduces the risk of SUDEP. This means ensuring that patients are compliant with their medication, avoiding stresses reduces that risk of SUDEP. Patients should be made aware of their individual risks so that they can make informed decisions regarding their clinical care. So in patients who have just received a diagnosis of epilepsy, it's important that they commence anti-seizure medications promptly, as well as take them regularly without missing any doses. In people who live alone, monitoring devices may be really useful in quantifying seizure frequency, particularly if they're unaware that they're having seizures. This may be used to identify what type of seizure that they're having, how frequent, and then how to treat that. Patients should speak to their neurologist or epilepsy nurse for more information around SUDEP. In patients who are having ongoing seizures despite the use of multiple anti-seizure medications, prompt referral to a tertiary epilepsy centre for consideration of advanced therapies such as epilepsy surgery or neuromodulation such as vagus nerve stimulation or deep brain stimulation, as well as dietary therapies which may reduce the risk of SUDEP, should be considered. It's really important to remember that patients and their caregivers, when asked, about 90% of them wanted to know about their risk of SUDEP, but in reality only 30% were actually given adequate information.
If you talk to families of people who have died of SUDEP, the number one they say is, why didn't anyone tell them that they could die from this condition? No one ever told us, no one ever told them. If they had have, they would have taken their tablets more regularly or treated it more seriously. There are things we could have done.